Yeah. Sepsis clinical laboratory aspects, we try to discuss this large topic. The first question is very interesting. So do we know at all what does it mean sepsis? So we're looking for a definition for more than 30 years. And today the answer may be but discovered by Sir William Osler. Except a few exceptions, the patient seems to die from the body's response to infection rather than from it. So it's very, very important. So the body's response, this is the most important. So what we can find is it's a war. We can find many pro-inflammatory and anti-inflammatory signs inside on our body. Maybe you know that the definition of the sepsis is changed some years ago. So previously we used a little bit different definition when we try to describe what does it mean sepsis. If you compare this new definition and the earlier definition, the most important differentiation between them that SIRS is not part of the definition now. And the other, today we don't use severe sepsis, but the other it's the same. So what does it mean, the sepsis today? So sepsis is a life-threatening organ dysfunction caused by a dysregulated patient response to infection. In lay terms, sepsis is a life-threatening condition that arises when the body's response to infection causes injury to cells and its organ. And the most serious picture what we can find during the septic shock among these patients with sepsis who develop underlying circulatory and metabolic abnormalities resulting in hypotension that require vasopressors, and they have very high lactate level despite adequate volume resuscitation, and unfortunately resulting in a higher risk of mortality. And this is the brand new definition that we try to use today. For example, in the emergency room or in the intensive care units, of course, we try to describe with some easy steps the possibility of the sepsis of our patients. And many times we use, for example, the SOFA score when you can see the following parameters, but we have to check for the definition of the score, of this score. And it's very important because if we found very high scores, we have to use prompt therapy. And if we suspect some kind of infection, of course, we also have to use special antibacterial therapy and other intensive care. So this is the summarization of this definition. And many times we know this as bundle of care. So here you can see the first important, we have to measure lactate level. And after we repeat this measuring. And very important that we collect blood culture from our patient, theoretically prior to administration of antibiotics. It's very important because with these blood cultures, we try to identify the valid causative agents if we suspect infection. And after we should start broad spectrum antibiotics, or on the basis of the predisposing factors, we suspect some microbes, and against them we try to use the most effective antibacterial therapy. And of course, we have to solve the hypotension, and we also have to use vasopressors if we find some parameters. It's also very important that not just microbes, but many others, for example, major trauma, circulatory shock, tissue necrosis, or anaphylaxia or apoptosis, also can trigger this process. And after, inside of the body, we can find many changing, and we can monitorize or we can check some of them. And unfortunately, later, when we can find organ dysfunctions, of course, we also can check with different parameters these steps. But if we focus to the microbiology, so if we try to focus to the microbiological background of sepsis, in this slide, you can see which can be the trigger for this process. We learn many different type of microbes, for example, gram-negative, gram-positive, or fungal agents. And if you remember, if we focus to the gram-negative bacteria, the most important is the lipopolysaccharide, which can be found in every gram-negative bacterial cell wall, and this is the bacterial endotoxin. Of course, this endotoxin will bind to the binding protein, and if we check very precisely, we can find that the amount of this LBP may be increased by 100 times at the beginning of the infection. And after this complex, that lipopolysaccharide and lipopolysaccharide binding protein complex will bind to the special receptor on the outside of monocytes or macrophages. And after, the cytokine production, tumor necrotic factor production will begin. And of course, we know some receptors in other parts of our blood circulation system. So bacterial endotoxin, this is the very important if the causative agent is gram-negative bacterium. And the other, the gram-positive bacteria, maybe you remember, here we can find in the bacterial cell wall proteoglycan layer, so it's a very special layer, and many of them also contains teicholic acid, which also can trigger this process. And many other bacterial products and extracellular enzymes and toxins, such as streptokinase of streptococci or streptolysine O, also of streptococci, or alpha-hemolysin of Escherichia coli, or for example, Pseudomonas aeruginosa toxin A, and many superantigenic type toxins produced by streptococci or staphylococci can trigger this process. And Candida species, if we focus to the Candida species, here you can see that the MON9 is the most important, which can be found in fungal cell wall. And after, we can see these inflammatory responses, and after this, we can check the different changing in the body. What are the questions? The first question always is the inflammation. If so, what causes? So can we identify of participants? And after, what damage has been caused? And of course, if we start our treatment, we would like to check the response to our treatment, and we would like to check the progression rate. And of course, we have to follow this process. But unfortunately, we have many problems. So generally, we want to characterize the local process, but use sample from a systemic source, so we can collect very easily blood sample. And the next, that the systemic appearance of each localization is very variable. Try to think, for example, to blood-brain barrier, abscess, or lymphatic system. And which is also important, we would like to check the timely, very dynamically changing parameters. And unfortunately, many of them has very low specificity. And theoretically, because we have to work in the laboratory with the different machines, it is recommended to examine parameters that are stable enough, so detectable under laboratory conditions. And of course, maybe you know that the different measuring instruments have very, very different sensitivity. So it's very important. You always have to compare these laboratory results with the clinical aspects. What we can check with these laboratory investigation techniques, we can check the qualitative blood count, of course. We try to check the leukocytosis, the toxic granulation. We can check the eosinopenia. We can check the cells, the count of thrombocytes. So here you can see that during the early period, we can see thrombocytopenia and later thrombocytosis. And which is very important, and later we will discuss, we can check the different acute phase proteins, Procrastipanine, C-reactive protein, and we also can check, for example, anorganic phosphate concentration. And maybe you know that between the gram-negative and gram-positive bacteria, we can see some differentiation. We also can check respiratory alkalosis and later metabolic alkalosis parameters. We also find hypoalbuminemia. And if we check the coagulation system, so before the organ damage, we can find protein C or antithrombin deficiency, D-dimer elevation, and PT and APTT elongation. And we discussed earlier the lactate levels, which is very important, and it belongs to the tissue hypoxia. And later, when we can find the organ dysfunctions, we can check, for example, with the creatinine levels, the renal impairment, and we also can check the different enzymes with helping we can monitorize the liver damage. And of course, many times we can find changes in carbohydrate metabolism parameters. And you will be clinicians, so you will find in your patients many times, for example, fever, which is also belongs to the inflammation and infection. And maybe you remember that we differentiated between the different type of fever. So for example, returning fever, so it's very characteristic during the purulent processes and for example, during Mycobacterium tuberculosis caused infection. And the other example, the intermittent, the septic fever, when we can find very high temperature rise and chills, and it belongs, for example, so if we find this one, maybe we can suspect pneumonia and cystitis and pyelonephritis, or after sepsis from these sources. And sometimes we can find a continuous fever. The definition of this is the daily fluctuation within one, and it's characteristic for the viral infections and also for the bacterial endocarditis caused by the different agents, but it also can be because of the tumor malignancy of our patient. And we learned the special biphasic fever type when the fever and the febrile days change. And in micro, we learned the malaria, the Plasmodium falciparum and other species cause the malaria, but it also can be found during the Hodgkin disease. And we don't like the definition of the fever unknown origin. So when we don't know exactly what is the problem, so what is the cause of the fever. So the largest part of this may be the infection, but many times we can't identify it, or we can find a very rare causative agent such as Brucella or Coxiella or something else. But connective tissue diseases and also the malignancy, or sometimes we don't know, and we won't find the answer to this question. So just some picture from these laboratory investigation techniques. So blood count during the acute bacterial infection, of course, many times we can find elevated white blood cells. And we also have to check after this step the qualitative blood count. And here we will find leukocytosis. So more than 80% of leukocytes belong to the granulocytes, and many times we can find the left-handed blood count, so the number of the steps elevated, and in some special cases we can find toxic granulation. I would like to show you this picture because it's very funny. Here you can see that these blood smear revealing activated neutrophils, phagocytic bacteria, and free cocci in clusters. So rarely we can find this picture during the Staphylococcus aureus caused septicemia. And the other parameter during the sepsis, what we can find many times is the eosinopenia and thrombocytopenia. And if we compare this acute bacterial infection, for example, with the tissue necrosis and sterile inflammation, you can see that in this second case, the granulocyte count increases slightly. And during chronic inflammation, typically we can find normal white blood cell count and maybe monocytosis. Many years ago, for the infection, we tried to check the erythrocyte sedimentation rate. So this was the Western green. You will learn many data from this nice and old technique, but it's very important that it has many pre-analytical and laboratory factors which can change the validity of this rate. Of course, for the collection, we have to use a special tubes, which is a citrate-containing tube, and the ratio of the blood and citrate is very important, because more citrate will cause higher erythrocyte sedimentation rate. And how we check this parameter? So it's very important for us to have to check at room temperature, and the timing is also important. So it should be started within 2 hours, and many other pre-analytical laboratory factors can change the validity of this parameter. But we know the reference range for men and for women. So here you can see it's a little bit different. And we use, because it increases proportionally with the acute phase reaction, but it's very slow because it will grow just after 1 day, so after the onset of inflammation. So it's too late for us if we would like to promptly solve our patient problem. And many other component in the blood has specific influence to this rate, and many other specific parameters can change the count of this parameter. So here you can read some example. So maybe red cell disorders or anemia, or if the patient had taking some different drugs. And in this next slide, I try to summarize factors increasing ESR and factors decreasing ESR. And the next important question, can we check the acute phase reaction? And if we can, how we can check it? So what we can check. Among them, the most important is the procrastipanine and the C-reactive protein. And of course, here in this slide, you can see many other components which also belongs to the positive or negative acute phase reactants. Of course, the changing of these parameters, it's very important. So it belongs to the collection time of the blood from our patient. So theoretically, we always have to know where is our patient. So when we collect the blood from our patient, and after we try to follow this process. What we have to know from the CRP, we know that the production occurred in the liver, and calcium binding protein consisting of 5 subunits. Can be up to 20% of the proteins produced in the liver during the acute reaction. And it can bind to endogenous and exogenous ligands and promotes their opsonization. For example, here you can see that the endogenous can be dead cells or cell fragments, and exogenous bacteria, yeast, and parasites. It's a very active complement. It will stimulate phagocytosis and binds to Fc receptors in lymphocytes. How we can measure? Of course, we have to collect serum, blood with this typically red cap tube from our patient. But from the emergency room, for example, many times we use heparin samples. And for the investigation, for the measuring, we use immunoassay-based measurement with different sensitivity. Today, we use hypersensitive CRP test because this is the most sensitive, of course. We have reference range, which is lower than 5 milligram per liter. We can find very high degree rises in the level of bacterial infection. After a day, we can find elevation of this parameter, and after the peak concentration will be after 2 to 3 days, and the half-life of this parameter is a few days. And we know that this level will increase during fungal viral infections, but also after local lesions, or after trauma, or after surgery, or sometimes during autoimmune diseases. And because of this knowledge, we have to underline that it's very sensitive but non-specific parameters to the acute sepsis. And in this slide, I just try to summarize the basic differences between the ESR and CRP. So why we prefer one of them, but of course today we use and we prefer the CRP protein because it's a bit better. And the next one is procalcitonin. This is the propeptide of calcitonin. It produced in the C cells of the thyroid gland. And intestinal and pulmonary production may be present in the context of infection. Theoretically, we don't know the exact special role of this, but we like using this one because during sepsis, during the inflammation, it will be sooner positive than C-reactive protein. Here we also try to use a reference range which is lower than 0.5 microgram per liter, but it always depends on the suspected infection and condition of our patient. In this next slide, you can see the comparison of CRP versus procalcitonin. This slide tries to summarize for us the advantages and the disadvantages. So if you remember to the earlier information, response to the infection is much rapid with procalcitonin, and the half-life is also shorter. So it's very important because we can follow our patient in time, but unfortunately the price is higher, but it's not so important. And the other special and interesting knowledge that especially if the suspected causative agent is some kind of gram-negative, we can find higher procalcitonin level than the causative agent is gram-positive bacterial agents. During the viral infection, we can find usually normal procalcitonin level, but of course it can it may increase during the severe condition. And try to think, for example, to the COVID pandemic. So among COVID persons, we can find very high procalcitonin level. Which is very important, and maybe I told you earlier that one measure is not enough. So it's very important that we have to use these parameters, not just CRP, but also PCT, rather for monitoring than just checking one step, because we have to follow their dynamics. So it's very important. And the assessment of certain of a given procalcitonin should be in different ways, because of the etiology, because of the onset of disease, because of the anamnestic data. And of course, the other problem also can elevate the concentration of the procalcitonin in the patient sample. So which is very important, we have to follow. And for example, in the literature, we can find many nice studies which try to recommend that if we can find decreasing of the procalcitonin level, we can stop the used antibacterial agent, because we solved the problem. But unfortunately, we also can find some other nice study which tell us the totally opposite. Of course, if we have diagnostic techniques, and if we have many other investigation possibility, we can check many other biomarkers, for example cytokines, and many others, for example hepcidin, or you can read here many others, but of course normally we don't use them in every day. And now I just would like to tell you two cases when I try to underline the importance of these parameters. The first case report, here you can see it's a nice a little bit older woman who was in the nursing home, and here the assistant found fever, feeding and drink difficulty. And in the emergency department, of course, from the blood samples, the colleagues try to identify that this is sepsis or not. And before start antibacterial agent, they collect urine and blood culture for microbiological examination. And later, from the lab, we got these information. So very, very high white blood cells, and of course, almost neutrophils and thrombopenia. And here we also can find some parameter which connected to the impairment of the renal function or liver function. And I underlined the CRP, which was much, much higher than the cut-off ratio. And this was the first day, and because in the urine, in the emergency department, the colleagues find pyuria. They think that it can be a urinary tract infection, so they started therapy with ciprofloxacin, of course, in addition to supportive treatment. But the second day, they got call from the micro. So unfortunately, the blood culture is positive, and in this blood culture, we found gram-negative rods. And of course, we also checked the urine sample, but because this is the second day, we know just the causative agent, which is Escherichia coli. And of course, resistance in this day is in progress, because just after 1 day, we can tell the result of the antibacterial sensitivity pattern. But unfortunately, the condition will be worse, because here you can see that CRP is much, much higher than the previous days. So it's maybe 400 milligram per liter, and the Prokaryotonin level is also very, very high. And in this third day, we know the total microbiological result. So we know that in the urine, we found ciprofloxacin resistant Escherichia coli, and after the colleague changed the treatment, so they changed to rocephin. And after, because it was successful, here you can see the slowly, but we can find much, much lower CRP or Prokaryotonin level. And after 3 weeks, every parameter theoretically can be found in the normal regio. And the second case report, it's a man, and here we can find the intermittent febrile condition, and because of the CT and because of the other suspect, the clinicians think so it's maybe abscess in spleen. The microbiological diagnosis of this is not so easy. And here you can see that in case we can find too high white blood cells, and maybe we can find thrombocytosis and not thrombocytopenia, and the other parameter is normal. But CRP, it's a little bit higher, and we can find just, so it's not so high Prokaryotonin level, because it's abscess, so it's a local infection. But later, here you can see that after 2 and after 5 days, unfortunately, the CRP will be elevated. So after this step, we have suspect, so maybe our therapy is not so successful. And here the colleagues collect aspirates from these abscess and start treatment with the meropenem. But unfortunately, the microbiological result was Fusobacterium nucleatum, and after consultation with the infectologist, the colleagues had to change to piperacillin tazobactam plus metronidazole. And after this step, so here you can see the main differentiation. So in the 8th day, the level of the CRP is just half than the previous. So after this step, we will be sure, yes, this is the optimal treatment for our patient. And lastly, just some words from blood culture, because this is maybe the most important microbiological investigation. So it's very important, and you always try to remember that the sensitivity based many factors. So when collect blood culture, how collect, the volume, the frequency of sampling, the choice of blood culture bottles, and of course storing and transporting blood culture bottles. So it's very important. We have to collect at least 40 milliliter from that person during the normal sepsis, because the recovery of the pathogens is much higher if we collect enough volume. But of course, during endocarditis, we have to collect a little bit more. Because the background is that during endocarditis, the concentration of the causative agents in the blood is much lower than during other sepsis. Here you can see that we can use, for example, aerobic bottles and anaerobic bottles. And here you can see Staphylococcus aureus and here Pseudomonas aeruginosa. But for example, for the if we would like to check children, we have to collect blood from these very small patients to the special PED bottles. And how long we have to wait, how long we have to incubate these blood cultures. Today we think that 5 days it's enough, because after 5 days we can't catch any valid causative agent, just the number of the contaminants will be elevated. And maybe you know that the microbiology today, it's not the same it was, for example, 10 years ago. So today we can use many modern techniques with helping we can answer in time. So we can use, for example, molecular techniques. We can use multi-TOF MS system for the identification, and for the sensitivity test, we also can use some rapid technique. Here you can see, for example, this multiplex PCR with helping we can check the most frequent causative agent. It can cause sepsis in our patients. Thank you very much.